In addition, this meeting, as an appendix to the usual paper, there was an ask in a couple of meetings ago, I think it was, for whether there was any modelling that we could look at to predict the position going into the winter months. So we have looked at that, and the paper is attached. The models are, it's not massively conclusive, I have to say, because models are very difficult to predict, to get the right information within them to predict. But what we can say is that we do need to remain cautious. So, as I've just explained, our vaccination rates in Luton are lower than other boroughs. We have seen rises in rates during the autumn, largely driven by school-aged children. There is this new variant of interest. There is also winter pressures coming in through backlog of illnesses and presenting in health and care settings. So it is looking like over the winter that we will be experiencing high pressures in demand for health and care services. There is some evidence that the government models that we've been looking at through this paper, so there's two models that we've looked at, one called Nowcast and one called SPI-MO. There is some evidence that they so far have underestimated the predictions going through November. But those models currently suggest that we've had a bit of a peak and we're going to be reducing in our case rates going into the new year. So, I mean, that's positive, but there is some evidence to suggest that that may not be the case, or it may be an underestimate, particularly in Luton, where we know that we've got low vaccination rates and have historically had problems with community transmission and enduring transmission. It also doesn't necessarily take into account behaviour change that we're likely to see going into the winter months with cold weather and people more likely to meet indoors, particularly some of the large multi-generational gatherings we see in Luton, and some of the increased, obviously, shopping and everything else going into the winter season that we will see nationally across the country. So there are some graphs and other data within the paper, which I'm not going to go through in detail now, but you can see, and that's all based on the models that I just mentioned. They don't predict very far into the future. So the figure 4 has some predictions going into the end of December in terms of case rates, and it predicts a decrease throughout that month. And we can now, with this paper, update its live data feed, so we can just click to update the graph and it pulls the data through. So we can bring this paper back at future meetings. But in conclusion, the models suggest that we will be seeing declines in case rates, but it's quite unpredictable. And we know that in Luton we have specific risk factors such as low vaccination rates that make it even more questionable. So vigilance is required still going into the winter months. Thank you.
Thank you, Sam. Any questions? Yep, Councillor Ugby.
Thank you, Chair, and thank you for the report. In terms of the variant of interest, what you call Delta Plus, do we know in terms of test and trace, what percentage of Luton residents fall into this category?
So we know from, so we get what's called a line list. So any of the cases come through to a data system that we can look at and have a sample of those that are tested for variants. 13 to 14% of Luton cases in the last week were this variant.
So do we know in terms of the population, which population is more affected in terms of whether it was BAEM or it was no?
No, we don't know for this variant particularly. I think if we get more data, it's quite small numbers at the moment because it's a subsample of all the cases, and I don't think it's done. I don't think we have the data by ethnicity, but I can ask the question of our analysts and check. I think at this point it would be too small sample anyway to be able to tell, but I can ask the question and I can bring that back.
And also, do we know if we can find out areas or whether it's concentrated in certain areas of the town so that we can prepare just in case it becomes the ones that we need to deal with, we are in a better position to do that?
Yeah, I can ask that question, and we'll continue to monitor it really closely because it's quite new information, this, and it needs quite close surveillance. So we'll be looking at it closely, but I will definitely follow that up.
And my second question, Chair, is to do with hospitalizations. Do we still, you mentioned the number, I'm not sure whether you said 14. Is there 14 in hospital?
I said 51 patients in the L&D at the moment.
So is it broken down into gender and into ethnicity? Do we know?
I don't have that on my reporting. I'll ask the question.
Okay, so it's important that we do know there so that which communities are affected most, that can be dealt with. And in areas where we think the vaccine uptake is low, we can be prepared to do something in those areas. So I'll be keen to have those data so that we can maybe home in and make sure that we do. I know we're doing our best, doing taxi stuff. The council is doing as much as it can.
Yeah. So we weekly look at the whole picture of the epidemiology and by case rates, by group and by age. The specific weekly L&D hospital patient data, we don't look at that by that. But what we are doing, I don't know if you remember, maybe 6 months or so ago, we bought a I can't remember what we called the title of it, but looking at the disproportionate impact across different groups and different cohorts across the course of the pandemic to date. And we're just working on that being refreshed. So we'll bring that back in my update in the next meeting.
Thank you.
The Disparities Report, we were calling it. Sorry, slipped my mind then. Yeah.
Councillor Fetts.
Yeah, mine is kind of a follow-up on David's. The 50 people in hospital and the 9 people that have died, do we know how many of those were vaccinated?
We don't specifically. We do know that obviously being vaccinated greatly reduces the risk of going into hospital. But we have asked that question before, and I don't think we have that data by vaccinated and unvaccinated. We do know anecdotally, in a broad sense, that the majority of people that are needing to be hospitalised now are unvaccinated or have 1 dose. But I can't say exactly the numbers, the proportion.
Could we pull that data out for the next meeting? Because it would be quite interesting to see, and if possible, by ward as well.
I can certainly have a look and see what we can get. I think a deep dive into the hospital data that we can get hold of would be helpful. So I'll have a look and speak to our analysts about that.
Okay, thank you.
I have a question as a follow-up to that one, Sally. Is the vaccination status, are we using that as part of the education campaign for vaccination, or is it just too anecdotal to use that?
We haven't been specifically in terms of our hospital admissions. We have been discussing whether there's some stats that we could be using as part of our communications messaging. So there was a study recently that showed that if you're vaccinated, then the death from COVID is 32% less likely if you're vaccinated, which is it's very powerful if it's said right, but it's difficult to land properly. So we need to be careful on that. And likewise, there's some stats around hospital admissions nationally that we have been talking about whether we can use. So we are looking into that.
Thank you. Anyone else? Okay, thank you very much, Sally. Item 8, the population wellbeing strategy.
Thank you. Hold on, I just need to put it up on my. Okay, so the population wellbeing strategy, I think I brought to Health Scrutiny, feels like a lifetime ago now, but quite a while ago, and we've been doing lots of work in the background since, and it is a live, ongoing piece of work. So it's not just a strategy that then sits there and we don't do anything on it. So as you're aware, it's a key strategy that delivers against Luton 2040 ambitions. So we've got the population wellbeing strategy and the inclusive economy strategy, and they're the two key drivers of Luton 2040. So the population wellbeing strategy is in your papers and is wide-reaching across the life course. So just flicking through the pages, hold on. So it summarises the position in Luton and then talks through the key challenges and the key ways in which we're going to address the challenge and drive forward the population wellbeing agenda in Luton. So just to summarise some of the key issues in Luton and challenges that we're facing. So life expectancy and healthy life expectancy in Luton is below the national average and is stagnating, so is not improving. There's a significant housing challenge with high levels of homelessness and below average home ownership. Unemployment and economic inactivity are higher in Luton than nationally and have grown since the pandemic. And the most deprived parts of Luton have experienced the most severe impact from the pandemic. So we know that a large proportion of cases of COVID have been in the more deprived areas. But there are a lot of assets in Luton that we want to build on through the strategy. So we have a population of 213,000 and have a growing older demographic, but have one of the youngest populations in the country. Diversity is growing and is one of our key assets, and is constantly changing as well. So our Eastern European population continues to grow. We have really good parks and green spaces with Green Flag Award to 6 of our Luton parks. And 80% of our school children in Luton attend a good or outstanding primary school, and this is improving. So there's some really positive things happening in Luton. However, there's lots of areas that we need to be tackling and addressing through our population wellbeing strategy. So we know that there's high deprivation in Luton. So we're currently ranked 70th most deprived out of 317 local authorities. And there's areas in Luton that are in the top 10 most deprived in the country. We have, as I mentioned, significant housing challenges and increasing number of households set to be at serious financial risk, and more than a third of children in poverty pre-pandemic. So just in the slide pack that you've got, there's laid out the population wellbeing strategy recovery plan. So the Luton COVID-19 population wellbeing recovery plan, which lays out how we're looking to address population wellbeing coming out of the pandemic. So really highlighting supporting the national response through the local response, tackling inequalities, learning from what we've had to have in place during COVID, and building back healthier and fairer coming out of COVID, and then meeting our long-term ambitions for population wellbeing. So this is really cool, forms a backbone of the strategy. So the strategy itself is across the three life. It has the life course approach. So it's set across the life course. So 3 key areas. So starting and developing well, living and working well, and aging and dying well. And we have some key guiding principles. So we're looking at to be driven by data and insight, to have co-production and collaborative working at the core, to listening and responding to our communities, tackling health inequalities, thinking about social justice and equity, and learning from the pandemic and building on what we've experienced through the pandemic. So a key part of the strategy as we're building it in now is thinking about Sir Michael Marmot's approach to health inequalities and the work that he's done around the fair society and healthy lives, and thinking about the impact of a fair and just society on people's health and well-being. So in Marmot's work, he's got 6 policy objectives. So one of them is giving every child the best start in life. The second one is enabling all children, young people and adults to maximise their capabilities and have control over their lives. Third is creating fair employment and work for all. 4th is ensuring a healthy standard of living. 5 is creating and developing sustainable places and communities. And 6 is strengthening the role and impact of ill health prevention. So we're really looking to build those into the strategy and run through the strategy completely, and particularly thinking about throughout the strategy, building in the impact of COVID, thinking about health inequalities and building back out of the pandemic, and ensuring that we're not making, that we're doing everything we can to not exacerbate inequalities through the work that we're doing. So the strategy then goes on to highlight the key priorities across those life course areas. So in starting and developing well, it highlights the key priorities that we're looking to deliver against, and in the living and working well priority, and then again in the ageing well priority. So I'm not going to go through all of the detail underneath each of those, but they're laid out in the strategy documentation, and we're doing a lot of work in each of the boards that deliver against that strategy to work through the detail around the action plan, and what exactly we need to be doing to deliver against those priorities. So those are the bits that we are continuing to work on, continuing to review and report against. So the three boards that are working through the aims and priorities within the strategy are the Children's Trust Board, the Health Inequalities Delivery Board, and the newly developing Place Board will be a key delivery board for the strategy as well. So the detail of the actions are still being worked through for some of them, but are really coming on and really developing now and driving this forward. And then we're also doing a lot of work on the indicators that form the baseline of the strategy and can tell how we're doing and how we're achieving against the actions that we're setting out. So I'll stop there and open up to any questions. Thank you.
Thank you. Anyone?
Hi, sorry, this is the first time I think I've read this report. So in page 36, when you talk about improving health and wellbeing for people with mental health conditions, you talk about social prescribing and the concept of social prescribing. Could you tell me more about how we're approaching that in Luton and how we're using that concept? Or will do?
Yes, so we've got a really well-established social prescribing programme in Luton, and it's delivered through Active Luton, who are commissioned to do our lifestyle services. So it's part of our lifestyle services and embedded into that contract, working very closely with GPs and the social prescribing link workers within GP practices as well. So there's a lot of work on that in Luton already. So we were obviously in the last 2-3 years, it's become really big nationally and had a lot more investment in it across the PCNs in primary care. But Luton actually has had a social prescribing programme way before that. So we're quite ahead of the game and quite well established in our social prescribing programme, getting lots of referrals, but continuously looking at how to develop that and improve pathways and make sure referrals are coming in. So there's a lot of work on that, and I could happily bring back a report specifically on that if people were interested in hearing more about social prescribing service.
So on the deprivation in Luton, it says that Luton is currently ranked the 70th most deprived. It was ranked 59th. Do we know why we've had that improvement in the last 5-6 years? And also the proportion of areas of Luton in the top 10% has gone down. Is there can we identify any reason why that has happened?
I think it's difficult to pinpoint it down to one thing. It will be through a lot of collective work of lots of different areas. I'd like to say some of the work of public health, but I'm sure it's lots of different areas of work. So it will be to do with employment, education, housing. I can't really say, to be honest, but there's a lot of work that goes into lots of different areas that will be contributing to that.
So none of the KPIs that we're measuring are indicating perhaps why this is happening, or is it just too small of a change to?
So the deprivation measure it's a composite indicator based on lots of different factors, and then there's a ranking. So it's difficult to know from that specifically what it is that has brought those areas out of the ranking to have that improvement. If we track back on our KPIs over that time period, it might be able to give us an indication on what specifically has has affected that composite indicator. It might be an interesting piece of work actually to have a look at that, because the KPIs that I've presented here are just the most recent data rather than over the last 5-6 years. So again, I can have a look at that and see what I can pull out from that information.
Okay, thank you. Councillor Rugby.
Thank you, Chair. Thank you, Sally. For me, one of the questions that keeps coming back from residents is that most of the strategy, we keep talking from 2020 to 2040. In terms of recovery from COVID, do you have any specific timelines? The question is, we're going to do that at the 2040 end or in between the two? So if you can specifically put times on when you think we are targeting to recover from the COVID, and specifically what measures have been put in place for those with, say, or the Mammoth Review has said is mostly affected, which is the under 65s, Black and Asians minority groups. Is there anything specifically that needs to be done? That's my question. The second question is, I'm the councillor for Southwold, and as you know, the report that say that's one of the most deprived areas. What specifically programs have you put in place to make sure that the residents in Southwold are able to recover to meet the basic standards so that they can also enjoy in the recovery process? I haven't seen anything in terms of timelines and specific programs put in place. So if you can please comment on that. Thank you.
Yes, so there's lots of things in there that I want to comment on. So we've done quite a lot of work through the last year on the disproportionate impact of COVID in Black and minority ethnic groups. So we've done a big piece of work with the University of Bedfordshire to understand that impact and to try and develop solutions together to ensure that disproportionate impact doesn't continue to drive inequalities in those groups. So we are just in the process of developing an action plan coming out of that piece of work, and the full research report is about to be published. And I know I keep saying I'll bring that back, but actually I do think that would be a really good thing to bring back to this group, to hear the full depth of the findings from that study, and also what we're taking forward now as our actions from that. And that will have a timeline on it in terms of the actions, but it's a long piece of work, so it's not a quick fix to some of those things. And in terms of the timeline for COVID recovery, and when we're hoping to see, milestones on the data, it depends what element we're talking about, whether we're talking about employment or actually health indicators specifically. So it's difficult to say exactly what timeline we're looking at, but we do need to build that into the strategy as we go forward in terms of what we expect to see by when. And then the last thing I wanted to say on that was that we are looking at developing the Marmot approach to some of this work a lot more fully, with the University College London as a partner in that. So the university and the department where Sir Michael Marmot actually works to develop some of this, to embed some of the policy initiatives and drives around that into our approach, and to develop Luton to be a Marmot town in the same way that Coventry is a Marmot city, to try and embed that into what we're doing. And through those conversations with Sir Michael Marmot's team, we'll be able to look at how we evaluate some of that work as well. So what we could expect to see by when, and how because all of this is really long-term incremental changes that everybody needs to pull together to be going towards the same aim. And that's why the 2040 ambition is so long-term, because these are big things to change and turn around. But through the conversations with Sir Michael Marmot's team, I hope to be able to say what we can deliver by when, and what changes we can expect to see, and learn from Coventry, because they've done a lot on this, and have seen their deprivation rates. Their ranking has improved massively, but they've been a Marmot city for 9 years, I think. So it's, you know, it's long term. But again, if we bring back the Talk, Listen, Change project, which is the research we've done with the University of Bedfordshire into the disproportionate impact, the Marmot work is coming out of that. So if we bring that back here for a discussion, I can bring the Marmot piece within that as well, and present back on both of those pieces together.
That's all fine, but for residents, I think they want to see somebody responsible to say, I'm the responsible person, and I can assure you that there's X time that has been put on this, and if there hasn't been any improvement, hold me responsible for that. I think any report that's going to come back, I'm not sure when it's going to come back. I'm not sure whether I'll be here by 2040, what COVID has taught us. There's no guarantee in life, but I think we should be thinking seriously about improving people's lives and life chances. We cannot wait till 2040. I don't think I'll be here to see 2040. So please, I want to see something back quickly as possible. And the second question is, as elected representatives, do we have any input into this? Are we going to be part of the solution? Nobody has said anything. So can you tell us, are we going to be part of the solution? Are we going to be involved? Our ideas taken on board, sitting on some of these, but looking at what's going on to say, look, you need to do this. And this is a question coming from residents. Thank you, Chair.
So there's another few points that I want to make. So we also, as part of, sorry, my microphone's a bit odd. As part of the COVID recovery work, we're also working very closely with the voluntary and community sector, and have just launched what we're calling the COVID Recovery Fund, which is small grant funding that voluntary and small voluntary sector organisations can bid for. BLCF are coordinating that for us, but it's really aiming to meet some of those issues that you're talking about at ward, at local level, so people can use the funding to support and build back better. So it's very much around some of the issues that we've been talking about, but to do some work now. So we can send out more information about that with the papers. And then absolutely get involved with the Talk, Listen, Change inequalities work that we're talking about. Yes, absolutely happy to get input into how we take that forward, thinking at a ward level, and in local communities. So yes, by all means. So we're looking at probably doing an event with the community around that, and very happy to get input and input into that.
Thank you. I guess as members of this group, we will have inputs and the ability to comment on all of these plans and whatever. Thank you, Sally. Sorry, Steve. Yeah.
Just one more. In page 46, in the section talk about increased physical activities, just one thing that surprised me more than anything else is that, see, you got the smoking prevalence in adults, and that says worsening, which is the thing that surprised me, mainly because anecdotally I thought things nationally particularly were improving. You see less and less people smoking. I just wondered what kind of timescale that's been worsening across, and if it is worsening against a picture of a general improving in that statistic elsewhere.
Yes, it is worsening in Luton. Our rates have gone up of smoking prevalence. I can't remember off the top of my head the time scale that's comparing to, but as a general answer, yes, our smoking prevalence has increased in Luton.
Yeah, but talking about is that something that is also true across the country? Do we know?
No, it's going down across the country, but has increased a bit in Luton.
Do we know any specific reasons why, any factors that could be?
No, apart from that, we know smoking prevalence is higher in more deprived areas, routine and manual workers. It may be to do with more higher take up in young people in Luton than in other areas where, you know, if more people are taking it up at younger ages, then obviously the rates will increase if that's happening at a faster rate than people are stopping smoking. But why that's more of a case in Luton comparatively, I don't know. But I think we are doing work on that and prevention, working with schools. But we could perhaps be looking at that more. But it will be related and all interrelated to deprivation and inequalities, because we know that in areas where there's greater poverty and deprivation, there are higher rates of smoking.
Thank you.
Yes.
Yeah, just a quick one on this smoking issue. I certainly got the impression in the Eastern Europeans, the rate of smoking seems to be, you know, very, very high. Is that the area where it seems to be going up?
I don't know if it's increasing in that area, in those groups, but they generally, nationally, there are higher rates in Eastern European and white other population groups. Yes, that's right. And we know that population group is growing in Luton, so that may well be a factor as well.
Okay, anyone else? Okay. Thank you very much, Sally. Item 9, modernising inpatient mental health services in Bedfordshire and Luton. This is Richard or Eugene?
Yes, hello. Good evening, everyone. Can you hear me?
Just about, yeah.
Okay, Eugene, service transformation. I think you have within your packs our summary and slide deck. Ordinarily, I would take you through the slide deck. I'm not too sure how you'd like to manage the coverage of the item today.
Unless you want to put this back into Richard is available.
So
The end of the agenda.
we can do. So you don't have the. So what's the?
Well, I normally share my screen with you through the slide deck, but I don't think I've got that facility on here to do that. So I'd need permission from you, I think, to allow that to happen.
Chair, if I may advise, I wasn't aware that there was going to be a presentation. So it's a case of either Eugene presenting it from the report, which you've got hard copies of, members have, or perhaps wait for Richard to join us at 7 o'clock, when he might be able to be more prepared to do a report for you, as he has done in the past. Eugene is here as in the contingency in case Richard couldn't join us. So if you want to either go through the report from the papers or wait for Richard to join and present it.
I'm happy to go through the papers with you. So I'm au fait with the detail. So if you want to proceed, I'm happy to.
Yeah, I think, yes, that would be the best idea if you would.
Okay.
Yeah, thank you.
Great. Okay, so this report identifies the outcomes of the case for change engagement, which took place over a 6-week period from the end of August the 31st, until Friday, October the 15th. And it was widely canvassed and advertised across central Bedfordshire, Bedford Borough and Luton to engage all stakeholders in the our case for change, which is around modernising our inpatient mental health services. In terms of the outcomes of that, what we were seeking is to gauge opinion from stakeholders in terms of our proposals, but also to identify any questions or areas that we hadn't yet explored, which we would then incorporate within our programme going forward. In terms of the outputs themselves, a really positive engagement from the vast number of people actually that were involved in the actual survey and online survey and workshops, around 270 respondents, of which 93% agree with the proposals themselves. We have a small percentage of people who neither agree nor disagree, a very small number that disagree, and an even smaller number that strongly disagree. So real strong weight of opinion behind support for the proposals themselves. We've had also a number of areas that we need to consider more and in further detail around the areas of the proposals that people wish to understand more about. And they are a number of areas, including timescales, travel, the actual conditions that we would look after, whether we factored in population growth and other areas. So a number of areas that we need to consider further, which we will do on our journey to develop this proposal. There's some further areas around things that we haven't yet included, for example, around parking, recruitment, crisis support and other services like secure services and addiction dual diagnosis. We've had further feedback around areas that people don't agree with. So that was around detoxification wards, when this will happen, no mixed wards, older adults care, disparity in Luton spend, impact on Luton sites, and various other areas of feedback. Within the slide deck in your pack, you'll have some of the comments that we've received from stakeholders, which I won't go into now, but you will have seen those. In terms of the demographics themselves of the survey respondents, the vast majority were within Bedford Borough, so residents of Bedford Borough, over 70%. And in terms of central Bedfordshire and Luton, around the same number of respondents, so just under 15% of respondents hailing from either central Bedfordshire or Luton. In terms of how people describe themselves in relation to the project, around about 25% ELFT employees, around 20% service users, just over 10% of carers, and local residents just under 30%, so 28%. So again, quite a good range of people that have engaged in either the online survey or the workshops that we held around this. In terms of people's age, we again, quite a good coverage. So we've had people under the age of 18. So part of these proposals, as you'll be aware, are to develop a children and young persons unit. So it's really good that we've got engagement from people who are of that age, under 18, and also people in the older adults as well as working age services. In terms of demographics, we need to get under this a bit more, but we have found that over 80% of those respondents were classified themselves as white. And obviously that isn't representative in terms of the Bedfordshire and Luton demographics. So we need to understand how we can engage more across the spectrum of people and residents within Luton. And in terms of gender, we have identified also that there was more female respondents than male respondents, and then a smaller grouping of other gender classifications within the within the returns that we received. So in conclusion, we had 4 questions that we were asking, and we had a kind of resounding support for the overall principle and vision to develop and modernise these services. We have some further areas to examine in more detail, and we will do so as part of our pre-consultation business case, which we now will be engaging in to develop and refine that further detail to explore those areas in more specific areas. And also in terms of engagement, we can see that the engagement itself is not entirely representative of the local population, and we need to understand how we can engage within particular communities and groups to really hear the voice of everyone and all residents around this vision, which we will do as part of our journey and the pre-consultation business case and further engagement sessions and work as we go forward. I'll probably just end there, and then I'd be happy to answer any questions that you may have.
Thank you. Anyone? Jeff?
From what we hear in the media, it would seem that the mental health services in this country, in most areas, are in a state of collapse. How do you respond to that?
Well, I think health services in general have had a very difficult time, and I think you've heard some of that from colleagues in public health related to COVID. Mental health services themselves have not been immune to those impacts. But in terms of the local services, we have a real opportunity here to develop and modernise those to create what we aspire to, which is a centre of excellence. And there are certainly other units across the country which are in a much poorer state. So, there are units still, sadly to say, in this country that have dormitory style accommodation with no private bedrooms, and they exist still even now. And so privacy and dignity is obviously completely compromised in such an environment. We have very large wards, again, in some places across the country, and we're looking at our new facilities will be conforming to the Royal College of Psychiatrists guidance around the optimum size for these wards, so that the staff don't get stretched. They can spend enough time with patients on a one-to-one individual basis, and that we can support people's recovery and journey to discharge and home as quickly as possible. So I do agree that there's been a crisis in healthcare, and I don't think mental health services have been immune. But I think this is very much looking at the future and what we can develop together to create what we're aspiring to, in co-produced terms, a centre of excellence.
Isn't it true to say that we were suffering a recruitment crisis in mental health?
That's true. Again, mental health care, and this is not unique to mental health. I think it's the NHS services or healthcare per se have experienced difficulty around recruitment. What we believe, though, is that these environmental factors, so these new facilities, both in terms of refurbishment and new build, will attract staff to come and work in Luton and in Bedfordshire to support local residents. And the reason for that is that these environments will optimise and enable staff to deliver the very best care that they possibly can. And sometimes environments that staff work within don't do that. They actually hamper that. So these environments will be guided by clinical staff and service users and carers, co-produced in that way to attract those staff, to retain them, so that the workplace really is an environment where they feel they can do their very best.
Thank you.
Thank you. Pat?
I mean, this was an online study and it was quite underrepresented by Luton, 15 residents. As COVID has identified, there's lots of deprivation in Luton and people don't have access to the internet or computers. So a survey that would involve that would not involve all the residents in Luton.
Yeah, so there was, thank you very much for that. There was two aspects to the gathering the respondents' feedback, if you like. So there was an online survey, and there were also workshops which were held. They were also virtual, again because of COVID restrictions and the ensuring that people were safe. So there were virtual workshops, of which there were 5, which were, in actual fact, the workshops were in greater attendance. There were greater numbers that participated in the workshops than did the online survey. But there are limitations, obviously, to the virtual online world that we're currently in. To some extent, our hands are tied on that because of the need to ensure health and safety measures, etc., are in place. But we will have, and we will endeavour to pursue further engagement with local communities, including those in Luton, to understand their feelings, hopes and wishes around these units and how we can make sure that they really do meet their needs both now and in the future.
Anyone else? Okay, thank you very much, Eugene.
Thank you.
Okay, on to item 10, Adult Social Care Strategy. Tamara and Elaine.
Good evening, everyone. My name's Tamara. I'm the Strategy and Implementation Manager in Adult Social Care. This is my colleague, Elaine Healy. And today we're just here to talk to you about the development of the Adult Social Care Strategy. We're hoping that this will be for 5 years, 2021 to 2026. In July this year, we had a number of engagement sessions with our internal and external stakeholders. And the purpose of those events was for us to get feedback on the draft vision that we have for adult social care, to get feedback on our priorities and the outcomes that we want to achieve for the citizens of Luton. As you all know, the landscape for adult social care is changing rapidly. We have legislative changes coming down track. And then following those legislative changes, we've also this year had the Health and Social Care Levy. We all know about Building Back Better. So we know that the strategy that we have to put in place has to take these changes into account. We recognise in adult social care that we may need to change longer term our operating models. That will involve working very closely with our commissioning colleagues and involving our finance teams, obviously, in that process. But what we ultimately want from the strategy is for it to be accessible to the local population, that they understand what adult social care means for them. And we also want to be able to outline what this will look like for the next 5 years. We hope to have a completed strategy ready for executive at the end of January 2022. As I said before, whilst it's a 5-year strategy, what we'd like to do is have a strategy with a 1-year implementation plan. It's important for us that we get the building blocks in place, the foundation right to start with, and this will be supplemented by quarterly stakeholder meetings and co-production group meetings to keep the strategy as a live document. We don't want this document to be something that just sits in a filing cabinet. In the pack that you have, you'll see the Appendix 1, and in there it outlined the framework for engagement that we had in terms of the sessions that we had. in there, it highlights what the challenges are for us. I'm not going to go through them, but we've got less money for social care, etc. Recruitment is an issue across the piece, and also the wider sector, our external private providers, are also experiencing similar things that we are in adult social care. Whilst we have these challenges, I do believe, and we want to reflect this in the adult social care strategy, that actually there are opportunities for us to work together with our external providers in a more integrated way. And I'd just like to draw your attention to point 11 in the report, our vision for the strategy. I'm going to read it because I think this is important. People in Luton with health and social care needs will lead a good everyday life with the people they value in the community they call home, with an equal voice in planning their own care and support. And we want that to be an integral part that runs through the strategy. Again, within the report, it outlines the priorities for adult social care. One of the priorities is actually we want to be able to co-produce with individuals the early support they may need to stabilise and maximise their independence, enabling people to stay at home for longer, looking at what strengths-based practice, digital solutions and community-based options we can support people with, and ultimately ensuring that we've got a highly skilled and competent workforce that can meet the demands of those, or meet the needs of those within our community. So for us, the outcome of the adult social care strategy is to ensure that people have their needs met in line with the wellbeing principle of the Care Act. And as I said, one of the key things for this to be a success is us having this implementation plan and the measures of success that go with it. We want to be asking, when we write the strategy, where are we now? Where will we be in 5 years' time? What will we do to achieve this? And what does success look like to you? So I'm ready to take questions.
Thank you. Anyone? Sorry, David. Yes.
At least there's a shorter timeline on this, so really pleased that it's 2026 and not 2040 that we can see. My question is to do with, in terms of staffing levels and what we do. As you know, there's being vaccinated, to be vaccinated has become compulsory for staff. And do we know if that has affected care in terms of in Luton?
At the minute, no, that is monitored on a weekly basis. I would have to defer perhaps to Sally in terms of the monitoring around vaccinations in care homes, but at the minute it hasn't posed an issue in terms of care delivery in Luton at the moment.
Yes, not a huge amount to add, but we there's data that we can look at weekly on the trackers from care homes around uptake, and also through the vaccination work streams that I sit on. So we monitor that closely, and the uptake in residents in care homes has been really good throughout. And we did see a lag compared to our neighbouring boroughs in workers in care homes, but that has, since it's become mandatory and the deadline has now passed as to when people needed to be vaccinated by, that has really increased. So our rates are up there now. And as Tamara said, that we have been monitoring against the market and whether people are leaving the sector and whether it's causing challenges there. And so far it hasn't been, but we are continuing to look at that. And the booster is obviously now coming in, so that's being worked through as well in terms of rollout of the vaccination programme to care homes.
At page 72 on my document, and it's item number 6, it talks about, I read, this may require longer-term changes to operating models, including commissioning of services and financial processes. There's a lot in there. I think previously we were told there was going to be a session on commission and providers. We haven't had that. What I want to know is, in terms of commissioning our services, is it still a race to the bottom, or we try and give the social care workers the best we can? Because the report that were coming those days where people have to use their own cars and now we're not being paid for it. So what has changed since then? Thank you.
Sorry, can I ask for clarity on the actual question? Sorry.
The question is this a race to the bottom? The person who comes to say, we're only going to pay £10 and we can give you all the services are the ones we pick during commissioning. Because I don't know what happened at commissioning and all that process.
Okay, I know, yes, sorry, I'm just checking I'm on. I know commissioning are looking at their current options in terms of the wider market. I know from a domiciliary care perspective, we're looking to go to tender, aren't we? I'm trying to answer, I don't actually work in commissioning, so I'm trying to give an overview of what I know without saying things that aren't quite true. Elaine, sorry.
So if it's in regard to the rate of care, then
Is it possible that we will see any data in terms of what you just mentioned about the commissioning and the financial processes? Because I haven't seen any data.
Chair, Elaine, would you mind using the microphone to the right? I think I can't hear you very well on that one. I think the microphone doesn't work. So that's why we set up. Thank you very much.
okay, so this is not a data strategy at the moment. While it will talk about the kind of amount of contacts, assessments, information and advice provided by adult social care, we want to start looking at some of the demographics as well in terms of our certain groups of people more likely to access certain types of services, because that informs development. What we can do though is take away, share with our DAS, who unfortunately is absent today, about the request and for more data in this area to be taken back to be reviewed by Scrutiny.
Perfect. Thank you. Thank you, Chair.
Thank you. And anyone else? Just have a couple of questions. I'm looking at the forward plan, and you said that the strategy will be ready by the end of January.
Yeah.
So the next thing that happens is that the executive approves the publication of the adult social care strategy. So that's not what does that mean? Does that mean that the executive are saying yes, go ahead and publish it, or they won't? Will they have the strategy at that point in time?
Yeah. So the full strategy will go to executive in January for sign off. We haven't been able to do as much consultation in advance because of the circumstances that other people have touched on. So when it's published, it's still a live piece of work. So we want to continue to consult on it as we go. So in our initial engagement, people didn't want us to overpromise and underdeliver. And part of the strategy since we started this in July, you know, we've had Build Back Better, we've had amendments to the Health and Care Bill. So it's very much just setting out initially what those legislative changes are going to mean ahead for us and setting out a 1-year implementation plan, which is very much those building blocks as Tamara's already touched on. And then we engage with communities about our vision, what it means to them and how we need to consider that in what we do wider. In terms of Health Watch engagement, we're also conscious of digital exclusion. So we, you know, as well as looking at easy read version to sit behind this strategy, we do want to have other forms of consultation other than online. So that might be a stall at a supermarket, within the mall, somewhere we can reach the public that we're meant to support, and potentially looking at working with some of our councillors, like ward forum type approach, to discuss what matters to them as well. It very much just is setting out the vision initially and the changes that we're going to have to be going through, and then building on that as we go.
Okay, thank you. Okay, thanks very much. I don't envy anyone who's trying to put together a strategy for social care. Thank you. Okay. Update on the impact of universal credits. Nigel?
Thank you, Chairman. Good evening, members. We present on the report the latest in the series of updates on the impacts of universal credit in Luton. I'm sure members will be very familiar with the format of the report, where we try and update on the previous data provided. So I'm not going to go through it in detail, but I'll just pull out a couple of points, if I may. The universal credit situation, obviously linked with the unemployment and the economy, remains changeable. And at point 5, that points out that the impact of people's changing circumstances really continues to force the natural migration of people away from housing benefit and to universal credit. So that is continuing. The information in the report represents the latest information we've got, but we are aware shortly that there'll be further updates, and we are expecting overall that the local data to follow the national data, which shows that overall claimant numbers are now falling. Point 12, as normal, highlights the breakdown of the households of most concern. And I know we got some questions last time on the housing element. So at point 18 onward, we've included an additional narrative there for members from the housing team, so obviously which is an area that I don't manage, around the current housing impacts, which I hope members will find useful. And as normal, the report ends with the monitoring and the normal RAG analysis. So happy to take any questions, Chairman. Thank you.
Yep. Amy? Yep.
Sorry. So on page 82, you talk about the percentage of households on universal credit who are claiming council tax reduction. That's 17.9%. Is that because the majority of households on universal credit don't have a child dependent, or is that because a lot of them don't know they're eligible to receive council tax reductions, or a bit of both?
Well, that is obviously an area, as we say in the report, we do use some data analysis from policy and practice, and we actually try and target these households to actually make them aware that they would be eligible for, for CTR. But obviously, it's not an automatic process, and we certainly need to get their information so that we can get get the claims through. But that is one area that, you know, we do proactively monitor and try and support with our colleagues in the customer service team, I would say.
Okay. As your ongoing collection of data, will that be able to pick out any effects that the recent cut in universal credit will have?
I think yes. So particularly the end. So the effect of the £20 uplift is that what you're referring to?
Yes.
I believe. Yeah. So that potentially may bring more people into claiming, but as I say, it does appear that that claimant numbers are actually falling. So we haven't got the detailed analysis yet, but I did see, not yesterday, an overview analysis which is following that. The other interesting point is obviously the end of the furlough scheme, and there was some predictions that may cause a spike in applications for universal credit. And again, the early data that we're seeing, I mean, we're only sort of a month since that ends, but it doesn't, yet again, it doesn't appear to be causing a spike to new claimants for universal credit. However, the team, it's an area we are closely monitoring, because obviously it is still a changeable situation, and we are thinking that there potentially might be an effect further down the line, and certainly when I should be presenting tomorrow on looking at the tax base and potential implications, we are looking potentially of seeing what the economic impacts post the Christmas period, and whether that might cause a change in the data. But as the data is at the moment is that the claimant levels are actually falling, and our CTR claim levels are also falling at the moment. So,
thank you. Anne?
I don't know if it's something you can help me with, but has the actual benefits office moved to Capability Green for people to sign on?
Okay, it's not. I am aware that the Job Centre Plus have put more resources in there, but certainly at the meeting that we've had with them, as stated in the report, we are trying to get back to our normal regular meetings with Job Centre Plus, but unfortunately we haven't been able to get their support in doing that at the moment, because they are. But I am aware that additional job coaches have been brought into that area. So.
But there are job coaches at Capability Green that people have to visit them there when they're effectively. Am I correct that we've got claimants that have to travel to Capability Green as opposed to going into the town centre?
I'd say I haven't got the detail on that, but I do understand that maybe when I can make that inquiry and respond in writing certainly after the meeting if that would be helpful.
I'd be really grateful, because what I've been told is the bus fare for people, they've got to get a bus into town, then they've got to get to Capability Green, back into town, and then back to where they live. So the cost is extremely high, obviously, for people who are on a very low income. So I just wonder if it would be possible to look into whether it could go back to the town centre. So at least these people who've lost £20 a week are losing even more money because they're spending it on bus fare. So I'd be immensely grateful if you would be able to. Thank you.
Fortunately, I was hoping to have my benefits manager with me who might have known the detail on that, but unfortunately she's unwell tonight. So if we can come back in by email, respond by email after the meeting, if that's okay, then we'll get an update from the Job Centre Plus on the current situation. Thank you.
Thank you. Thank you, Nigel. So we look forward to you coming back in 6 months' time with an update.
Absolutely, I think that would be good timing, bearing in mind the comments I've just made about the ongoing situation at the moment.
Okay, thank you. Draft work programme.
Chair, the work programme is as per the papers. Members need to discuss whether they agree with the current planned items, and if there are any further items to be added. I think we know that there's something perhaps about slippery cell that you would want to discuss.
Yes, well, there's generally we're expecting a health inequalities reports as well. So that will presumably be sometime in the new year. Okay. Anything that anyone else wants to add?